Well, hello, everybody, and good evening. Susan, thank you for that introduction. I'm happy to be here tonight. So we're going to talk a little bit of two different sections tonight. One will be a little bit more on the clinical side of what the importance of gastrointestinal blood panels are to us in private practice. And then we're also going to talk a little bit on the industry side about these new developments where you can now bring a lot of these gastrointestinal blood panel analytes right into your own clinics, which is very exciting for point of care testing. Here you see Henri. Can't do a talk anymore without putting a French bulldog into your talk since they're the most popular breed around. But as a specialist, I can tell just from looking at Henri that he needs a gastrointestinal blood panel. Why do I know that? This poor dog has no butt. Look at that poor guy. He's got nothing going on there. So he must be in need of some further testing. Again, I want to thank Zomedica. This is a sponsored talk this evening. Very nice for them to have me come out to see all you guys and hopefully learn some new information. As Susan said, you might want to take a look at this screen, and my email is there. If you have questions about this presentation or anything in general internal medicine, please feel free to give me a holler. I'm an Ohio State guy, Colorado State, and actually do quite a bit of work there at the clinics now, which is nice, and spent most of my career in Tampa, Florida. But today, I'm actually coming to you live from Marathon, Florida, which is in the Florida Keys, because the last Wednesday and Thursday of every year in July, they have what's called the mini lobster season, where we're allowed to get in the water and dive for lobsters. So here you see from this morning, my two good buddies, both veterinarians and co-owners here with me, Doctors Wehrman and Lutz from St. Petersburg, Florida area. So we had a great morning out on the water. Okay, so guys, talking clinically, let's talk a little bit about chronic, recurrent, persistent GI signs. Usually what that means is a dog has had signs of GI disease, either consistent or again, intermittent, but at least 2 to 3 weeks in duration. Most of the time that's diarrhea, vomiting, appetites changed, weight and loss, and condition loss. And when we look at those dogs, in the majority of those cases, if we were to biopsy the gut, as you see here in this photo, you would find inflammation in the mucosa and possibly deeper layers. And it can be a mixed variety of inflammatory cells, most of the time lymphocytes and plasma cells, so that typical lymphocytic, plasmacytic enteritis. And there are some common features or architectural changes. The villi tend to atrophy and fuse. You can see up here they get fibrosis as well as inflammation. The lacteals sometimes can get dilated if it's a more serious condition. When I came through school back in the late 1980s and what got into my internship and residencies, anytime we saw a patient, we biopsied them. We got our endoscopes out. Those were fun toys to play with. We had just started using them in veterinary medicine, and we biopsied everybody. And everybody that had inflammation and chronic changes like this was called inflammatory bowel disease. And again, we thought that everybody then needed steroids, that this was probably some form of an autoimmune type reaction. And we carried that out for almost 15, plus years, and even longer than that, almost 30 years as what we thought was going on. We called it IBD. Well, that's now changed. Since about 2015, we've recognized a new term that shares those same characteristics, and we call it chronic enteropathy, and that's the current terminology. And the reason we call it that is we recognize now that there are different diseases that respond to different therapies, but they all have the same characteristic clinical signs: inflammation if you biopsy their guts, and the architectural changes. So CE is kind of an inflammatory disease, but it's an umbrella term for a lot of different disorders. And again, the good news is we don't have to biopsy as many patients anymore to hopefully help them out. So here's the umbrella. Again, a number of papers published since 2015 that tell us that these dogs, what is it that goes on? Again, back when I was young, we thought that most of these guys were steroid IBDs or cancer patients, sometimes infections. But as you can see, that only takes up a small portion of the wheel. Maybe 15% of the umbrella is actually those diseases. The vast majority are food responsive enteropathies, especially if they're a younger patient, especially if the colon's involved with mucus or blood in their stool. most of those guys, if we're diligent enough as veterinarians and owners to do proper food trials, and there's a lot of different diets that might be useful in those cases, many of those patients will get better without anything else being done. So again, it's a big talk. We won't do it tonight, but again, recognize that you have to be very diligent and convince your clients that food trials are a good thing. But let's be honest, guys. I mean, I know as well as you do in private practice, it's hard to do regimented food trials. A lot of owners just don't always do what we ask them to do. Even when we ask them nicely, it doesn't always get done. So looking at the rest of the wheel, we have some things like microbiome responsive enteropathy, which means, again, if we can manipulate the bacterial microbiome through diet, through probiotics, many of these patients will, again, improve and get better. We also recognize that low cobalamin plays a role in chronic GI disease. Addison's disease, hypoadrenocorticism, plays a role in the same types of clinical signs, as does chronic pancreatitis. So again, we've got a number of things. These are just not all steroid responsive patients. And we have easy testing that we can do, oftentimes in this 35% through blood testing, where we can look at pancreatic values. We can look at cortisol levels. We can run serum vitamin B12 levels. Again, we can do folate levels, and we'll see the importance of these in just a second. Or we can use the feces as well to do dysbiosis indexes. So all of those things on your left-hand side are not specialty tests. There's nothing that says that I have to do them because I'm a specialist. Everyone who's a veterinarian, these are veterinary tests. These are ones you should be doing in your practice long before you're ever thinking of biopsying. I oftentimes like to do these blood tests first because, again, I know that I'll likely do food responsive trials on many of these dogs. But if I can find something easy and pick it off the list, I'm going to do that before I put the client through, again, what can sometimes be a laborious thing to do food trials. So what are these blood panels? We used to talk about them being, again, something that was done further down the line in a workup, a phase 2 or phase 3 test. I think they're phase 1 tests for these chronic GI dogs. So again, a blood panel consists of a cobalamin level, a folate level, trypsin-like immunoreactivity determination, pancreatic-specific lipase, and definitely a cortisol level as well. We won't talk about feces tonight, but fecal panels to look at these dysbiosis indexes are also very helpful because, again, they can give us a lot of information as to whether we want to try to manipulate or influence that microbiome. So as far as GI blood panels, what are the indications? Well, look at this dog. He's definitely looks fairly healthy, but thin, lean, and he does have pretty bad diarrhea. He hasn't been eating real well. So any patient that has changes in appetite, diarrhea, vomiting, weight loss, condition changes, and you don't suspect or find any other issues that are systemic or non-GI related, then these are patients that should get GI blood panels right from the beginning. Simple thing to do, guys. It's a simple prep for the client. Let's fast that dog, no food. They can have water for 12 hours. And then let's simply collect a serum sample. And we can look at, again, these different analytes to get some idea of whether these other diseases are participating in causing their GI issues. So with a single blood sample, we may be able to diagnose cobalamin deficiency and treat it, hypoadrenocorticism, GI bacterial imbalances, dysbiosis, if you will. We may be able to regionalize where in the small intestine their problem is. We know that cobalamin deficiency is an ileal problem. We know that folate, as we'll see in a second, is something that's processed in the usually duodenum and maybe the upper jejunum. We can, again, look at pancreas and come up with diagnoses like exocrine pancreatic insufficiency or even chronic pancreatitis as a cause for these patients' issues. And again, it's nice to do these before I get involved with a food trial for these guys. Now, early in my days, what we had to do with all these tests is that they had to be submitted to reference laboratories. And usually they were specialized reference labs like the GI lab at Texas A&M or university laboratories. And oftentimes, again, we had to bring patients back in after we first looked at them. We may have only done these panels on their second or third visit. And sometimes it took days in the beginning or even weeks for these results to come back to us. So it oftentimes delayed our ability to tell whether these conditions were part of these patients' chronic enteritis type issues. So let's take a look at the test individually, and then we'll go into talking to you about the new developments that will allow you to do most of these in your own clinics. Let's take serum cortisol first. We don't know exactly what the role of steroids are in maintaining homeostasis in the GI tract, but we know it's important. If you take the adrenal glands and wipe out that zona fasciculata, and our ability to make cortisol drops to very sub levels, like less than 2 micrograms per DL, or if you're from Auburn today, 55 nanomoles per liter, we're going to call that hypoadrenocorticism. And we know that as soon as the glucocorticoids are the most important hormone in the adrenal glands for the GI tract. Sometimes we'll call this disease glucocorticoid deficient hypoadrenocorticism. Most of us know the term atypical hypoadrenocorticism, meaning electrolytes are normal. And the new term, which kind of is more encompassing, is now called EEH. So eunatremic, eukalemic hypoadrenocorticism. And again, all these patients have the same signs you'll see with any chronic enteropathy. They won't eat properly, they vomit, diarrhea. The signs are often vague and nonspecific. They can gradually wax and wane, and sometimes they have normal days, then bad days. But again, the same signs that would be characteristic of any chronic enteropathy. Some really nice papers that have come out in the last couple of years talking more about this eunatremic, eukalemic hypoadrenocorticism. And so if you haven't taken a look at those papers, I'm sure you have, but if you haven't, they're really nice ones to review. One of them just came out here in 2024. I think it was from Italy, actually, Dr. Tardo's papers. So Addison's disease is easy to diagnose, right? I mean, we all know the gold standard diagnostic test is an ACTH stimulation. But I'm not here to suggest to you that you should do an ACTH stim in every patient with chronic GI disease. That would be a bit laborious and a bit expensive. But we do know if we wanted to do it, we would be able to demonstrate that these adrenal glands, once we give them synthetic ACTH, when they're destroyed, they simply cannot make enough cortisol, either in the pre or the post ACTH sample. But again, it's pretty expensive. Cortisone is not always easy to get. So really, we desire a much simpler and hopefully less laborious, less expensive screening test to simply say, does my patient who has chronic GI disease have Addison's disease or not? I'd like to be able to rapidly screen and really say, hey, if they don't have it, I want to move on into something else. So that's where we can oftentimes, guys, look simply at a serum basal cortisol. We know if your cortisol level's less than 2, you certainly might have Addison's disease. But we also know that healthy dogs and non-adrenal sick dogs that have other disorders also oftentimes, as you'll see from this chart, can fall into here on the right side, cortisol levels that are less than 2. So the bottom line is it's not a very specific test to diagnose Addison's disease. And again, I'm not looking to diagnose it, I'm looking to rule it out. If the patient is below 2, then I'll have to do further testing like an ACTH stim to then see in more detail or try to confirm that diagnosis. But if my cortisol is above 2 micrograms per DL, or again, above 55 nanomoles per liter, it pretty conclusively rules out Addison's disease. 99% sensitivity. Notice there's no one up here. All dogs that truly have hypoadrenocorticism are going to have cortisols less than 2 and usually less than 1 or non-detectable. So this is a way that we can say, hey, this patient quickly and easily doesn't have Addison's. We can take that off the books and not have to pursue it. So a wonderful screening test that, again, you can do right in your clinic on day 1 to take this disease out. We can rule it out quickly. Okay, second thing in a GI panel, let's look at vitamin B12, cobalamin. Dr. Cather did a wonderful paper. It's now 5 years old, but reviews cobalamin status in dogs and metabolism. It's an awesome paper. If you really want to know everything in detail about cobalamin, that's the place to go. Now, cobalamin is a water-soluble vitamin, and dogs and cats simply can't synthesize it. They are reliant on dietary intake, and they also have to be able to absorb this vitamin into the bloodstream through the intestine. It's got a pretty complex passageway through the stomach, into the intestine, carried to the ileum, where specialized receptors will then allow the absorption of cobalamin into the bloodstream through the ileal mucosa. Intrinsic factor is a very important thing that complexes it in the intestines and carries it to those receptors. An intrinsic factor is made mostly in the pancreas. So as we'll see in a few minutes, if you have pancreatic disease, you very likely will be cobalamin deficient as well. What's the importance of cobalamin? It's a real important cofactor for a lot of different nucleic acid synthesis processes in the body, the citric acid cycle, which is otherwise known as that famous Krebs cycle. And if you guys want, when I'm done with this lecture, 8 o'clock, we could stay on till midnight or 2 a.m. here Eastern Standard Time, and we could go through that Krebs cycle. But I don't think you really want to do that tonight. So we will just simply say it's important to run the entire body. You have to have cobalamin as a cofactor to form energy and live. Now, what causes low cobalamin? Look at that intestine up here. This is an ileum. If I go back a slide, see if I can do that. Yeah, look at this ileum. These beautiful villi, they're not blunted. There's lots of absorptive capabilities. And then we go to this ileal picture, this histopathology. Any type of chronic distal or diffuse small intestinal disease, whether it be inflammation, parasites, neoplasia, food responsive enteropathies, all of those will impact the ability of the intestine to absorb cobalamin. And even dysbiosis will screw up cobalamin metabolism. The bacteria that are in abundance that maybe shouldn't be there actually will compete and sometimes steal your dog or cat's cobalamin, and this doesn't get the ability to be absorbed. I already mentioned exocrine pancreatic insufficiency. The pancreas doesn't make intrinsic factor. You cannot carry cobalamin to the ileum. Now, there also are a number of dogs that have hereditary cobalamin malabsorption. So we tend to see these dogs very early, sometimes only 4, 6, 8 months of age, or up to a couple years of age, where they don't have their specific diseases. I won't go through all of them tonight. They have different hereditary inabilities to process cobalamin. You can see the dogs there on the left side that we know have inherited problems: border collies, schnauzers, Shar-Peis, beagles, Yorkies, and then dogs that we think have it that are hereditary: shepherds, greyhounds, and bull terriers. I'll tell you a funny story about Shar-Peis. You guys know as veterinarians, you never want your neighbors to really know what you do for a living, do you? Because they'll come over to your house and they'll be bothering you for free advice constantly. I had a Shar-Pei I used to see in my neighborhood that was walking by, and he was so skinny like this border collie, even worse, just emaciated. And I always thought, boy, I don't want to get involved in that case. That poor dog's got a bad disease. He's so old and probably cancer ridden. Turns out one day the lady showed up, the owner, in my garage with the dog, said, "I heard you're a veterinarian." And I, of course, answered, "Absolutely no, I am not." But she figured out I was pretty quickly. And that dog was only 8 months old. And it did, in fact, have undetectable cobalamin level. The other thing, if you had a dog on exclusive vegetarian or vegan diets, because again, cobalamin is somewhat deficient in the vegetable world, you could, in fact, although it's unlikely, get hypocobalaminaemia. Clinical signs, again, GI disease, chronic GI disease is the #1 sign. So it's indistinguishable from other causes of chronic enteropathies. But in the congenital dogs or the hereditary dogs, there are other things that can happen. Failure to thrive, there's some immunodeficiencies at young ages, weakness, peripheral neuropathies, sometimes central neuropathies. You can get blood dyscrasias, anemia, neutropenia. And this is the one that we sometimes get confused by. We said Yorkshire Terriers, young ones, can get an inheritable hypocobalaminaemia, and they present with low blood sugar, high blood ammonia, because you need that Krebs citric acid cycle to basically break down ammonia. And some of your amino acids are then altered that create sort of a hepatoencephalopathy appearance. So again, anytime you get a dog that's a Yorkie or a similar breed that maybe you think has a shunt and their bile acids are normal and you cannot prove they're a liver disorder patient, always remember hypocobalaminaemia can create that problem. The importance of recognizing these dogs is that until you supplement cobalamin, they'll never get better. Doesn't matter whether you put them on the best diet or you deworm them or you do anything that might correct other issues. Until you identify and correct their serum and tissue cobalamin levels, they simply can't get better. especially from the gastrointestinal side of things. So how do you diagnose hypocobalamin, guys? It's just basically, again, a serum fasted cobalamin determination. We'll talk about this little machine that you see right here, a bedside machine in a little bit, but you can either send it out to a lab anytime you see such a skinny dog like that little guy. And basically, what I want you to realize is, from a standpoint of diagnosing this, there's different consequences or different implications based on what your cobalamin level is. If we look at blood values, the high level is about 1,000. Anybody who's above 250 nanograms per liter is considered normal cobalaminemic. But if they start to get below 250, they are deficient in cobalamin, and you might start noticing some of those GI signs. If they get below 150, it's basically a non-detectable cobalamin level, and those patients are in severe disease systemically because, again, they need cobalamin to have so many different enzymatic functions. Now, we recognize in this that we like to target a number of 400 because 400 is in that lower 25% quartile of normal blood levels. But when you start seeing it down that low, especially if you have any GI signs, you're on your way to hypocobalaminemia. You're going to keep dropping down this list. So again, 400 is the target number for when we want to consider starting therapy with a cobalamin supplementation. How do you do that? You can either give parenteral sub-Q injections of cobalamin weekly. We used to do that all the time, but we now recognize there's multiple publications that also tell us we can, even in the presence of intestinal disease, we can give oral cobalamin supplementation, but you have to give it every day, and you would just use the label. This is one thing I would say. I would use the Cobalaquin product preferentially, because that one has had evidence-based studies that show us it is absorbed even in the face of GI disease and can help us reestablish normal cobalamin levels. Now, what do you do if you give the injections? You give them for 6 weeks in a row. Ideally, a month later, you recheck your cobalamin. It should be supraphysiologic, should be well up into that high normal range. If that's the case, if you have cured whatever you think created your intestinal disease, you can maybe stop it. You may not have to continue it. If there's a disease there that you're uncertain of or you did not cure, then I would just continue giving it probably every 2 to 4 weeks. A little bit different if you're giving it orally. You give it daily for 12 weeks. And then on week 13, so 1 week later, you would go ahead and rerun a blood level. And again, it should be in the high end of that normal range or above. And again, if that's the case, you've adequately supplemented this, and your patient should be doing better. Again, the use of it long-term just depends on whether your patient has redevelopment of clinical signs. Unfortunately, if that happens, or again, if you know you have a disease that you just can't cure, then it's likely it's still an inexpensive vitamin to take and use. Okay, so we're through 2 of them. Let's look at folate, vitamin B9. So unlike cobalamin, dogs and cats don't have to synthesize this. I'm sorry, they can't. They don't have to eat it in their diet, if you will. Folate is something that can be both eaten in the diet, but also produced by their own intestinal bacteria. So animal products, vegetable products are all going to contain a lot of vitamin B9. Dogs and cats would get plenty of it through their diet. But again, these little buggers here, these intestinal bacteria, can make it for them as well. So they are not as dependent, as we said, on eating that vitamin in their diets. It's only absorbed in the proximal small intestine, so usually the duodenum or the upper third of the jejunum. So this can help us localize where a problem may be in these chronic enteropathy patients. It is limited stability at room temperature, so after you do draw blood in a second, we'll talk about, you definitely want to refrigerate this and have it analyzed really as quickly and efficiently as you can. The reference range for dogs ranges from around 7.7 up to 24 micrograms per liter. So what's the significance of folate? Folate is a diagnostic marker. Again, beautiful paper from Dr. Eulaw talking about its use in dogs that goes through all the things in very good detail, published in 2023. So diagnostic marker, what we mean by that is if you run blood levels in a dog who's got chronic enteritis or enteropathy, and your folate level's high, so hyperfolatemia, that would suggest that you have excess folate producing bacteria in your proximal small intestine, which is dysbiosis. So we've made a diagnosis right there based on appropriate clinical signs and a high folate level. That's a patient that has an abnormal microbiome and needs to be treated for that. You can't overeat folate. There's no way you could ever take in too much. So again, if you see too much on your blood sample, it's from bacteria. A low serum folate or hypofolacemia, it could in theory be from dietary deficiency if you just were anorexic and starvation, but that's really, really uncommon. When we see it low, it usually means that it just can't be absorbed through the mucosal lining of the duodenum and the upper jejunum. So there's got to be some infiltrative disease that is going on at that site. So there's our bacteria that are making too much folate when you see elevation, so dysbiosis, and again, an infiltrative disease. So you need to go seek out what that disorder is. We need to do imaging. We need to do biopsies in many of these low serum folate patients. So as you can see, it's a good diagnostic marker to help tell you where to look in the body and what to do. If you find low folate, the first thing you want to do is correct that underlying intestinal issue whenever possible. So hopefully you can identify if they are a steroid responsive dog or a PLE patient, they have dietary hypersensitivities, whatever we can do to hopefully resolve that and get rid of it is the key thing in low folate. I get asked this question all the time. Should you supplement folate orally to patients when it's low? Is it necessary? People sometimes develop hematologic disorders, anemias, or immunodeficiencies. We really don't recognize that in dogs, guys. So it probably is not super important that you have to do it, but if you can get rid of the underlying disease, you saw my histopath slide just went away. If you can get rid of that disease and feel comfortable that you're controlling that patient's primary disorder, you probably don't need to give folate. They'll replenish it on their own because it'll be reabsorbed now. It can come through the mucosa. If you are uncertain and that level is really low, if you want to give a folic acid supplement, it's fine. It's safe. It's inexpensive. You can use over-the-counter folic acid. Smaller dogs under 20 kilograms get 200 micrograms a day. Larger dogs over 20 kilograms, 400 micrograms per day. Maybe a 30-day supplementation would likely give you enough driving force to restore normal folic acid or folate levels. But again, the key thing is treat the underlying disease, get rid of it, and your folate's going to go back normal. Again, there's not any big consequences with low folate in dogs. All right, let's move into the pancreas. So pancreatic specific lipase is an interesting chemistry value. It's been the bane of a lot of discussion over the last couple of decades. I'm going to try to break it down for you fairly easily tonight as to what I know after seeing the whole development of this. Pancreatic specific lipase means it's lipase that only comes from the exocrine pancreas. It's not made anywhere else. It's not made in your salivary ducts or in your stomach. It's exclusively from the exocrine portion of the pancreas. And it only enters circulation when you've got some active pancreatic damage or necrosis. So, i.e., you can see my little crying pancreas here. He's upset. And again, that's going to mean he's going to have lots of PLA or PL in those tears, and it's going to get into our circulation. So again, anybody that's got chronic enteropathy signs, chronic GI signs, really should have a PL level done to see if they might in fact have chronic pancreatitis, chronic pancreatitis or chronic pancreatic disease. Obviously, we know you do a lot of PLs when you have acute GI disorders and you maybe suspect pancreatitis acutely. That's certainly the other big indication. But tonight, we're talking more about chronic dogs, but I'll still kind of give you the overview of what I think of PLs. There are different assays that are out there on the market. There are immunoassays that are species specific. So you have a dog and cat antibodies when we look at these immunoassays. IDEX and the GI lab at Texas A&M have been the leaders in this field with pancreatic lipase. They have a quantitative laboratory species specific immunoassay called the SPEC-PL, as you guys probably know. There are some bedside testing now in your own hospitals that are quantitative. BioNote has had one for some time, and Truforma, our sponsor tonight with Zomedica, is the one we're going to talk about here in just a little bit. But that can now be done in your clinic with very rapid turnaround. They also have some semi-quantitative tests. The SNAP PL from IDEX is probably the one that you know most. And I'll show you why I have some issues. I'd much rather see you looking at a quantitative test through one of the companies that can put it either in your hands or a reference lab. Now, one thing you should know is there's always a big discussion between what's the difference between IDEC, the GI lab, and Antec. Antec uses a different assay. It's a DGGR assay, and I'll let you kind of sound out all that long molecular name that goes below it. But this is a non-immunologic colorimetric assay, and it has been shown that there is some lipase that comes from alternate production, not from the pancreas, that this assay can pick up. So there's always a discussion about who's got the best assay at reference labs. Practically, when you look at papers that have been published, there's not much of a difference. But historically, really, the SPEC PL is still your gold standard test. So here's my summary slide. I was involved back as early as 2012, even before that, 2010 and 29 probably we started at CSU. And when I was in practice in Tampa Bay, I was involved in one of the first research projects trying to use SPEC and SNAP PL testing to diagnose pancreatitis. That was the intention. We were hopeful that elevated levels would show us that a patient had pancreatitis. And it turned out, as you'll see here in a second, the opposite for us. Dr. McCord did a wonderful job with that paper, and I was on there with Dr. Tweed, one of my mentors as well. So here's what we think we know after 20 years of PL testing. It's best used as a screening test. Again, meaning that we're trying to go ahead and you get a normal level, you likely say the patient does not have pancreatitis. Specificity is not good in many of these tests. We know that there are lots of false positives. So again, if you're looking at a positive, we overdiagnose pancreatitis, and you certainly don't want to do that. You could miss other important diseases if you literally say that a high PL test means pancreatitis. It doesn't always, so poor specificity. We know that that PL, again, can increase from other GI disorders, foreign bodies, again, even any other type of inflammatory gastritis patients, all been shown to have high PLs. Also, other pancreatic diseases. Not everything of the pancreas is pancreatitis. You could have cancer of the pancreas that could do this as well. We know that immunoassays, though, a big advantage of them, they're non-invasive, right? We're not going to go biopsy and open up every belly of a patient to find out the gold standard is histopathology. We're not going to do that. We have assumed, and correctly or incorrectly, but probably correctly, we have assumed that the SPEC PL is the gold standard, and that's the test that everything else is compared to. We know that if you have moderate to severe pancreatitis, whether it's acute or chronic, you have a much higher likelihood. Sensitivity ranges up above 90%. So again, a negative or normal means you don't have the disease. Specificity, 80%. So it's better. But if you have less severe pancreatic involvement or chronic pancreatitis, it's sort of smoldering, but creating GI signs, unfortunately, your ability to use this test sometimes drops a little bit. So you have to put other testing methodologies together. You have to have a combination, a spectrum of tests to look at the pancreas. Don't always rely just on your PL value to tell you that you have it. We know that the SNAP test I mentioned before, I would rather have us using something else. It's a sensitive test, but there's lots of false positives because it starts at 200 micrograms per DL. And that is a low level where many patients, as you'll see in a second, don't have pancreatitis, but they can turn positive at that low level and give you these false positives. So bottom line, after 20 some years, is this test by itself good enough to rule in pancreatitis? And I think the answer is no. A couple years ago, Harry Cridge wrote a nice paper looking at that time at the test on the market. And bottom line became, look at these numbers. Again, if you were 200 or less, your negative predictive value was great, 100%. You didn't have pancreatic disease. But if you got up into the 400 ranges, your positive predictive values are still, in those 70, 60% ranges. And there's just a lot of false positives. So here's what I use it for. Guys, I want to use it as a screening test in chronic enteropathy patients. If they have a pancreatic lipase, a PSL, pancreatic specific lipase, less than 200, that is extremely reliable in ruling out pancreatitis. They don't have the disease, and I need to move on to some other reason for their chronic GI signs. So I would say that is trust the negative, trust the normal, if you will. Now, if they have an increased pancreatic lipase, again, usually above 400, but again, they don't have any other testing been done yet, that's not good enough to diagnose pancreatitis. You need to image the pancreas. You need to look at for other diseases in this patient, radiographs, because we need to know if they have another disease. So again, we have to verify a positive or verify an elevation in PL. So that's how we look at it currently. Trust the negative, normal, but verify positives. Don't take it as a blanket statement that they have pancreatitis. It's like putting a piece of puzzle together. You kind of think it's the pancreas, but we need to get those pieces in there to give us the fuller picture. And that means clinical signs are appropriate, radiographs are appropriate, rule out other things. Ultrasound shows pancreatic issues, and so forth. Okay, our last test, and then we'll talk about the Truforma assay, is the TLI test. So again, remember the pancreas is an exocrine organ as well as an endocrine organ. It produces digestive enzymes. We know those names, right? Lipase, we just talked about, amylase. But again, we also have a number of different proteases, trypsinogen, chymotrypsin, elastase, that are all there to basically break down ingested food into smaller molecular constituents that can then be properly absorbed across the intestinal surface epithelium. Here you see a nice photo of a dog that's, again, look at the atrophy, the small nature of that pancreas on an exploratory. This is going to be a dog that's not making enough pancreatic enzymes. On histopathology, you just don't see the exocrine pancreatic cells. There's some islet cells, but we just see complete absence or atrophy of their digestive or exocrine abilities. So if we can't break these foods down and digest them, then we can't absorb them. And these patients will then suffer from malnutrition, and they'll have all the same signs of any other chronic enteropathy. Again, beautiful paper just written, very detailed in 2024 from Harry Cridge and Dave Williams. If you haven't seen that one already, it's going to tell you all of the current thoughts on this disease. What causes exocrine pancreatic insufficiency? When they're younger patients, it's probably hereditary in most of them. I didn't put a German Shepherd in here on purpose, guys, because you've all seen that poor German Shepherd who's skinny as can be, standing next to a pile of loose poop. So I'm going to be nice and not profile the Shepherds, but they are the dogs that do get this disease with a higher prevalence. But also rough-coated collies like Lassie here, Cavalier King Charles, they get everything, right? Everything. Cairn Terriers, Chow Chows, Cocker Spaniels, Westies. And I didn't know what a Eurasier dog was. I had to look them up. They're a European German breed, and that's what a Eurasier looks like. Pretty cool looking dog. So younger onset of this disease, probably hereditary and atrophy. Older patients that suddenly develop chronic enteropathy and have loss of pancreatic function are likely going to have chronic pancreatitis. If you look back in their history, they may have had multiple upset GI tract issues over months to years that eventually led to the chronic pancreatitis and destruction of their exocrine cells. Occasionally, we'll get pancreatic duct obstructions from coliliths or masses that, again, don't allow. You can make the pancreatic enzymes, but you can't get rid of them into the intestine if you block the duct. It's pretty uncommon, and actually, we probably see it more in cats than dogs. Again, pancreatic enzymes don't only handle fat, they handle proteins and carbohydrates as well. You have to lose a lot of pancreas, though. Almost 90% or more of your exocrine acinar cells have to be atrophied or destroyed before you'll get clinical signs of this disease. Again, that's the typical poop that you see that comes out of these guys. And again, what happens is they can't break these proteins and carbs and fats down, so they can't absorb their stuff, and it just comes out the other end. They also get significant microbiome dysbiosis, because we already mentioned that they don't get intrinsic factor. That also leads to cobalamin deficiencies in these dogs. Again, there's the German Shepherd. Unfortunately, I guess I did profile him, but sorry about that. All right, the diagnosis of this disease, again, fairly easy. Simple blood test, fasted blood sample. There's a species-specific radioimmunoassay. Takes the same 12-hour prep. You can run it with the other things if you submit to a lab that does it. I will tell you right now that there is no point of care TLI testing in veterinary medicine. I'm very hopeful that someday it'll be there. I keep asking for it, and hopefully it will be produced someday. I think it's an important one to complete this GI panel. This diagnosis is made based on low TLI values. Recognize that elevated TLI values can happen with chronic pancreatitis, can also happen with kidney disease, but we're most interested here in low values. Again, you can submit this test to the GI lab, IDEXX, Antech. You can use the commercial reference laboratories when you want to look at pancreatic function. What are we looking for in dogs? We're looking for normal reference range, 10 to 50 micrograms per liter. We're looking for dogs that have the disease to be anywhere from 0, non-detectable, to 2.5 micrograms per liter of trypsin. And we now recognize there are some dogs that are sort of in a gray zone. If you're 2.6 to 7.5, that's pretty suggestive that you are an EPI dog. Maybe you just haven't gone all the way down yet. And I would likely go ahead and put a patient like that on therapy. If you're above 7.5 but below 10, you can't exclude EPI. You need to keep a close eye on that patient. Use your own judgment whether you want to do a trial therapy, or if they're not really bad clinically, you might give them another couple months and retest them. But again, we do recognize now that there is some gray zone values. But again, below 2.5, TLI is diagnostic for EPI. Therapy, I'm not going to talk a lot about it tonight, but again, we know you have to give these guys replacement therapy. Powders work better than tablets. Sometimes tablets don't break down real well. Expense is a problem for some owners. There is a company in Canada called Enzyme Diane that can produce packets of digestive enzymes and send them to clients for a little bit less money. You can see dosages there. One big thing that's kind of a tale of tales over the years, you do not need to pre-incubate food with pancreatic enzymes. It's fine to go ahead and give them at the same time as a meal. We don't have to pre-digest anything. It'll happen in the stomach and the intestine. All righty. Diet for these dogs. Remember that people sometimes think, well, I'll give them less fat in their diet. That even with supplementation, they still have some deficiencies, and they can still become very fat deficient and have trouble gaining weight. You want to feed these dogs not enteric low-fat diets. You want them on regular maintenance diets with the normal protein, carb, fat ratios. They're going to do a lot better that way and gain their weight back, and their hair coats will look better because, again, they're going to be getting more of that fat back into their system. You should probably feed them several times a day. Vitamins, again, cobalamin. Almost all of these dogs and cats are cobalamin deficient, so don't overlook that. Successful EPI treatment requires cobalamin. All right, so guys, let's talk now a little bit. Those are the things we look at in GI panels. So let's spend a few minutes talking about the industry side of this. So again, there's the test that we now want to run for patients: cortisols, cobalamin, folate. I don't know why I put folates on my slide. I guess it's plural today. Pancreatic lipase and TLI. Again, you could certainly send those out to a reference laboratory, or we can now do point of care assays in our clinics for all of these except for TLI. And we're going to talk again, because our sponsor here tonight, Zomedica, we're going to talk a little bit about this Truforma machine. It's a really cool, innovative, state-of-the-art, different assay. Traditionally, we've used quantitative assays that are immunoassays. They either use radioisotopes or enzymes or immunofluorescent light changes or chemilucent light changes. And basically, you take an antigen or an analyte. So let's say we want to look at cortisol, and we will go ahead and produce an antibody to cortisol and a label. And basically, when that antibody and cortisol come together, the label is activated, and it either emits radiation or a color change if it's enzymatic, or light fluorescence, or again, emits a different type of light with chemilucence. But you have this reaction that has to happen and be sensed. So immunoassays traditionally have been good tests for us. Their performance is good. They have high analytic specificity, meaning if the chemical or analyte is in your blood sample, it's likely to identify it. It's got good analytic sensitivities over the years. We can find little tiny amounts of these hormones or these chemicals or vitamins, and good precision. These tests tend to be very repeatable, and have a very low coefficient of variations. But there are some disadvantages. Radioimmunoassays emit radiation. We're not going to be doing those in our practices. The enzymes oftentimes are qualitative tests. So when they're qualitative, you're oftentimes, again, not going to get firm numbers. There's something called analyte-dependent interference, which means certain things that might be in your bloodstream at the same time, and we'll show you that in a second with cortisol, might interfere with the determination of what you're looking for. And there are analyte-independent interferences like hemolysis, lipemia, the anticoagulant ratio in your blood tubes, the effects of storage and temperature during shipping, and so forth. So traditionally, these have been mostly reference lab tests that you had to send out and take some time to turn around. Again, it would be nice to be able to do these bedside point of care in your clinics. So this is the state-of-the-art machine that's used now in most reference labs, the Immulite 2000 from Siemens. And again, they're just showing how they're doing pancreatic lipase here. Basically, they have a well that's impregnated with an antibody that detects and binds pancreatic lipase, depending on your species. And then they put in an antibody again, and that then binds on the other side as they add that, and it's got a substrate. In this case, it's chemilucent, so it will light up, and the light that's emitted can be then quantitated into how much pancreatic lipase is there. It's a nice machine. It does a great job. However, again, I like point of care things. This is the Truforma machine, size of a shoebox, sits on your countertop in your laboratory. Cool thing, it has an ability to play music for you. It's got a Bluetooth capability, so while you're running your test, you can listen to your favorite tunes. This is a totally different technology, bulk acoustic wave resonation. It's non-radioactive, no optics, no lights. So again, it's going to be unaffected by things like hemolysis and lipemia that might interfere with other immunoassays. It's quantitative, which is wonderful. We're going to get a precise amount that's in this sample. It's bedside, very nice. It's a closed cassette, so you have no reagents to mess with or deal with. It does its own quality control. And believe it or not, all those things equate to it's a very inexpensive technology. Why? Because it's sound wave technology. It's used in everything in our modern lives right now. It's used in broadcast radio, television, all wireless communications. They're all based off of different frequencies of sound waves. So you actually have this technology in your cell phone, in your Wi-Fi. I'll have it tomorrow when I am on an airplane. So again, it's out there and the components are inexpensive. I just put this in here. If you ever see a 100-foot cactus in the middle of the desert, the Sonora Desert, it's probably a cell phone tower. So it does have biomedical applications. We can use this type of assay to determine whether something is in a blood sample, like an infection, or we can say, hey, I want to know how much cobalamin or how much cortisol. I want to know the amount of a specific analyte in this. And again, we're going to go ahead and use this tiny machine to do it. Why does it do it? Or how does it do it? It's piezoelectric bulk acoustic wave resonation, or BAW. What in the heck does that mean? Pretty simple, actually. It's two metal electrodes that will conduct an electrical current, and it sandwiches a piezoelectric layer, which is made out of quartz, aluminum, zinc, different materials. And depending on the type of material and how thick it is, it will produce a typical or normal desired acoustic frequency. So again, we can manipulate and pick the frequencies we want. That's why you can have 4G, 5G on your cell phones. Where this technology first came out was a company called Qorvo Biotechnologies during COVID. Of course, everything, new things during COVID. And they were able to use this technology then to find COVID antigens, the SARS-CoV-2 antigens, at a point of care in your blood sample by using this technology. And I think I actually was in Cuba lecturing, and they may have used this machine before I could come back to the US to show that I was negative. It got FDA emergency use authorization in the US in 2021 because it was a good machine to show the presence of COVID. Basically, it can also not only find the presence of things, but we mentioned it can tell you how much of something is in a sample. And Qorvo Biotechnologies got together with our veterinary company here tonight, Zomedica, and they went in a partnership and said, hey, we can do a diagnostic platform that can give us accurate, rapid veterinary point of care testing. And they've now launched both endocrine hormone assays that you can do in your clinics, as long as the gastrointestinal assays we've talked about tonight, all of them except for TLI at this time. So there's just a sample of thyroid, TSH, cat and dog, free T4, cortisol levels, endogenous ACTH in both dogs and horses, actually. And then again, here's our GI panel now. CPL, again, pancreatic lipase in dogs, cobalamin folate for dogs, cortisol for dogs. Hopefully, we will see the feline species represented here in the not too distant future, I would hope. How does this machine work, guys? Again, pretty simple. It's a coated resonation plate, if you will, with an antibody, and that antibody will bind your analyte. You wash it through, you put again another in your wash or your next sample, washes through another antibody that will complex, and it is labeled. Basically, that label will then go ahead and it will become permanently bound to this plate. So if you've been passing electrical current and this is creating a sound acoustic wave, it's resonating at a certain frequency. If you add weight to that plate, it changes the frequency. And you can actually, in this sample, directly correlate the change in weight and frequency to how much of your analyte's in that system. So how much cortisol, how much PL. Really cool technology. Not influenced at all. It doesn't have to show light. Not going to have any misinterpretations from emission. No radioisotopes. Again, no influence of hemolysis or lipemia. There's another way you can do it as well. I won't go through all of this with you tonight, but it's another competitive where you can actually put the analyte on the resonating plate, impregnate that, and then wash through, and then inversely proportional, you can tell exactly how much of, again, the substances in your sample. This is the one that's used for cobalamin and folate, this sort of methodology. So again, it's just that change in weight changes that sound frequency, and then we can calculate, quantitate how much of our analyte is in that blood sample. So wrapping up, guys, how do I use this test? You know, again, hey, I'm in private practice. I'm in specialty practice. I am in a teaching hospital. I use it in all three places. It's wonderful to get rapid results and talk to clients. It's great when clients have been referred to me and I can give them rapid answers right away. I actually wish that you guys in general practice would have done it before me. And in the teaching hospital, it also gives us rapid results, but what a great teaching plan is my students get a result right now with new technology. They don't have to wait and come back to see me 2 weeks later when they're on the bovine service and come back and say, hey, Dr. Oswald, what about that? Did you ever get that result back? We got it instantaneously from a teaching moment, which is great. So last thing to wrap you guys up, I kind of put two talks together tonight. So I'm going to go a little bit longer than normal, so may limit some questions, but how do these machines perform so far for us with the Truforma? So looking at the cortisol assay, 16 minutes to a result. When you send it out, again, it takes a day or many days. The Imulite machine takes 30 minutes to give you a result. The dynamic range is excellent. It's very comparable to what you would find with the state-of-the-art or gold standard Imulite 2000. And again, so this is very useful for us from those two things. Rapid turnaround, instantaneous almost results, and it'll give us the same sort of values that we get. As far as coefficient variation or the precision, it's very precise. They've actually got this machine on a second generation assay now, and it's amazing how precise this machine is. So again, you're going to get the same value when you repeatedly run samples that are low, medium, or high levels of cortisol. As far as how does it perform compared directly to the Imulite 2000, the correlation is great. You can see that beautiful line. So again, it's very correlates. And your Bland-Altman plots, those tell you if there's agreement. So correlation is accuracy comparing two machines, and the other is agreement comparing two machines. It really stacks up and does very, very well. I mentioned interference before. On the cortisol, you do have to be aware of what your patient's taking, because whether it's the Imulite 2000 or the big lab or this machine, prednisolone, methylprednisolone, dexamethasone will all cross-react, just like they would with any other assay. So know what your patient's on. The cobalamin folate's kind of cool because, guys, you can run both samples on one cartridge. So it's able to do both simultaneously. Time to result, 24 minutes. And it takes the Imulite 90 minutes to give you results when they run those. Dynamic range for both cobalamin and folate is pretty identical. Actually, the folate level on the Truforma can be seen even higher, where the Imulite 2000 sort of cuts you off at 24. It says greater than. We can actually see, you get a folate that's 40, 45, 50. That is really high. I mean, there's probably no doubt that patient has dysbiosis. So again, it's a nice quantitative test, does a great job in clinic. The dynamic range, again, as I've already mentioned, can show you both high and low folate values, so we can get that diagnostic separation, again, that gives us the information we want. Precision, so again, the accuracy of this compared to the Siemens Imulite 2000 and the agreement, excellent. Does a really good job in the testing that's been done so far. And here you see, again, just those same cobalamin on the left side, folate on the right side or middle there, showing you those the correlations and the Blant-Altman curves. I'm not going to give you a lot of statistics tonight, guys, because I don't want to bore you to death. Really no cross-reactivity for other things in the bloodstream. Excellent. The PL test, again, less than 20 minutes to run it in your clinic, or when you send it out, it's going to take at least a day or several days to get back to you. Dynamic range is identical to what you would get at Texas A&M or at IDEX. The correlation, and again, the agreement level between the between the Truforma and the Imulite 2000, excellent, very, very nice. And again, very little cross-reactivity with any other type of lipases that might be present in that blood sample. So the wrap up, guys, pretty simple. You can buy a Imulite 2000, put it in your clinic, and you can get pretty instantaneous results. It'll only cost you about $150,000 for the machine, and lots of money for all of the chemistry samples that you will have to buy. Or you can get a Truforma, and maybe it'd be a little bit less expensive. And if you give them my name, it might be a lot less expensive. You say, Dr. Oswald said, I need to have this machine. I bet you can get it for next to nothing. Again, the prices and the technology is very inexpensive. The cost is in the cartridges. So again, there's the samples that we can run for GI tests now. PL, pancreatic lipase, cobalamin, folate, and cortisols. And again, there's the rest of the endocrine platform if you're interested in that as well. What I will tell you is that any company that puts things on the market needs to have independent validation. And on the endocrine side, a number of those have now been independently validated by very respectable universities or some really big time names in the profession. And they're in the process right now of doing the gastrointestinal blood panels. And I have every confidence that, what you see that comes out of the in-house Truforma data is going to be repeatable when you see it come out of independent validations. Again, it's done great on the endocrine side. It's such a unique technology. And it's so cool that it's inexpensive and can give you these results immediately without, some of the potential interferences with send out tests. So guys, I know you always ask me about cost in my last minute here. There you see what the cost of these cartridges would be for you. These guys can tell you, I think you invest in 10 cartridges. So if you didn't use them a lot, you're not going to have a ton of product sitting on your shelf.